Good evening, everyone. Thank you very much for coming to the Oxford Global Health and Care System Society McComas speaker event. We really appreciate everyone that's turned up, both those who are joining us physically and those who are joining us virtually via Zoom. Today we have Dr. Bruno, who will be speaking to us about the relevance of management sciences to global health. And we're also privileged to have in our midst the principal of the Green Templeton College here in person, Sir Michael Dixon. So I'll call on Sir Mike to please say a few words and then declare the event open, and then we'll proceed. Thank you very much.
Thank you, Francis. And I'm going to suggest that the speakers only remove masks tonight, and the rest reserve the precaution of wearing masks in public spaces. Thank you, Francis, for that introduction. I'm delighted always to introduce student-led society events, and the Oxford Global Health and Care System Society is no exception. I think it's great that we have these vibrant, active societies within college, run by the students for the benefit of not just the students, but many others too. So I'd like to thank you for your initiative in getting tonight's event together. I'm delighted too to welcome Dr. Bruno Holthof, our speaker tonight. Bruno is a former partner at McKinsey & Company, the well-known consulting firm, and during his period with McKinsey, worked with healthcare clients in Europe and the United States, and has gained significant expertise during that work in the areas of strategy, organization, and operations. He's an alumnus of Harvard Business School, where he received his MBA, and he's an MD, PhD from the University of Leuven. More recently, of course, he has been Chief Executive of the Oxford University Hospitals NHS Foundation Trust, of course, a very big local NHS employer that, of course, works very actively, as its name suggests, with the university. OUH employs 12,000 staff across 4 hospital sites and 44 other locations in the general area. Tonight, he's going to talk to us about the relevance of management sciences to global health, and I'd like to introduce him now to you, Bruno.
Thank you. It's a pleasure to be here this evening. You probably came here expecting that you would listen carefully and sit back and relax. Well, you're mistaken. So you may have wished you were on the webinar rather than here in person, because I got, as Sir Mike said, my management of business administration in Harvard, and Harvard is known for what is called cold calling. And cold calling means you call the student unprepared and ask him or her a question. And you're supposed to answer in a smart fashion. I'm not going to do that tonight. I'm going to prepare you for the question, so at least you're aware that you're going to have to participate. So Tunde was very kind to give me a title and say, "Can you please speak about this topic?" And I thought that's a pretty exciting topic, actually. What is management sciences? I had to sort of look it up to make sure that I was using the right definition. So I'm preparing you. I'm going to ask one of you, either as a volunteer, or otherwise I will, now that you're prepared, not cold call you, but do a warm call. Who wants to give an attempt at defining management science? What were you expecting when you were coming to this lecture to hear about?
Well, I was hoping to get an idea of whether doing an MBA would contribute to work in global health, but I recognize that management sciences is so much broader than anything you can be taught in a 1 or 2 year program. And there's probably a lot of it that happens outside of the university setting, and a lot more that's happening working in an institution than studying about institutions.
Yeah, it's a great point. I mean, we have the medical sciences division in University of Oxford, and you have the social sciences division where the State Business School is located. In Harvard, you have the Master of Business Administration in Harvard, but the PhDs in economics are not part of that. They're doctoral of business administration. So it's already a good point. So you're saying MBA may not be the full medical science, maybe broader. Anybody else wants to? Tunde, what did you have in mind when you when you put this forward? You can take off your mask when you're speaking. I think you'll find at least that you.
Right. So thank you very much once again for obliging the invitation to come. What I had in mind when I sort of couched the title was how to marry the two seeming alien worlds of healthcare and business in the broader sense. Because I essentially corrected myself as I get the impression, which worries me, that those of us who are passionate about health equity and that kind of thing, we tend to think that maybe commerce may not be particularly necessary. So my understanding is, how do you deploy the tools of management or maximizing the outcome of your resources, limited resources, but specific to the sector of healthcare?
Yeah, great. I'm picking up quite a number of words that we'll come back to. Anybody else wants to give a try? What were your expectations coming here of hearing about? Yes.
So I have a background also in health economics, and I've sort of been exposed to how I can apply health economics knowledge to sort of influence global health decision and justify whatever position taking as an approach to solve population health problems and all of that. So I'm here today to try to have a broader idea of other areas of management science that I can actually apply to solve global health problems, and possibly an intersection between the two fields, if there's any.
Yeah. So I went on the web and found this definition from US8, which actually has a couple of important words in it. First of all, medical sciences is a relatively recent science area compared to, for example, medical sciences. And second, it also says here that it includes the study of leadership. I didn't hear that yet. I heard about business, economics, but it's also about leadership. And applying it to healthcare, which Tunde's interest was in how can you apply some of this to healthcare, is even more recent. So we're going to talk about leadership and management. We're going to talk about how to apply it to healthcare. That's how I interpreted the exam question today. And just to illustrate you that medical sciences is a lot older, this is a building that you probably recognize. It sits next door. It is the Radcliffe Infirmary. And those who can read it and know Latin will see when it was opened. And that's in 1770. So more than 250 years ago, this hospital was opened in Oxford. Please recall the 250 years old. But actually, medicine was taught in Oxford already in the 14th century. So it goes back hundreds of years. Mike told me that I studied at the Harvard Business School. So this is from their website. We educate leaders. It doesn't talk about management. We educate leaders to make a difference in the world. That's why you're here in Oxford. You all want to make a difference in the world, in your own country. When was the Harvard Business School founded? Anyone who wants to have a guess? I'll tell you when. Yeah, today. Very good. It's the exact year. And so that is more than 100 years ago. And the next picture, today, when was the same business school founded?
15 years ago. 2001. 2001.
No, it's a bit older. 1996, 25 years ago. We actually celebrated 25 years. So it is a relatively recent institution. So I want to talk a bit about the difference between leadership and management. And I think this is a good definition. Leading well actually means leading teams. It's getting things done through other people. And when you want to do that, you want to absolutely build a great team. And you only build a great team when you have a shared purpose and when you have common objectives. We can talk about what leadership is all about. Management is a lot more technical. So it's more about using the right techniques, the right tools, often taught in an MBA, but not only in MBAs. It's about strategies, business plans, how to design an organization, and we need both. So it's not that one is better than the other, and actually it depends a bit on in what context you operate. But most individuals with a responsibility in society are leaders and managers. You need both. Now we also would like to make a distinction, like when you're doing medical sciences, you have quantitative research methods and qualitative research methods. You have the same in medical sciences. And this is a book. And I'm going to ask my second question here. What would be the content of this book? So it says an introduction to management science, quantitative approaches. So it's not qualitative, quantitative approaches to decision making. What would sort of be the chapters in this book? What would you expect when you open this book? What would you see? I don't know your name, so I'm just going to invite you to speak.
My name is Omar.
Nice to know.
I would say performance indicators or metrics that enable you to assess the success of a particular management model that you've implemented. Potentially maybe some like statistical models as well, how you can assess how well your structure is doing when you've implemented the intervention. Does it work? Does it not? Things like that.
Yeah. There's a lot of chapters on linear programming. And linear programming actually came out of sort of engineering and mathematics. And it was used to solve problems where you had to force constraints on the solution, and you were looking within a certain solution space to look if you could solve the equations. So that's linear programming. And actually, management sciences was the term sort of was developed coming out of mathematics and engineering, trying to, especially in the time when sort of Ford and the production methods were developed in the industrialization of the world, people thought you could sort of design systems, ignore people, and if you sort of designed the right systems, yeah, the production would be efficient. So that was the origin of management, the sort of the management sciences. And it's still, and this is a recent book, it also talks about waiting line models, which are actually sort of utilized in hospitals. In the Cranfield School here in the UK has a whole program on how you sort of model logistic flows in different sectors, including in the hospital. And they use waiting line management, queuing, and we all know that when you visit an outpatient area somewhere, people are just sitting there, and patients sit a lot in waiting areas. So that's another quantitative approach to management. Then the other topic here was a time series analysis and forecasting. Again, quite quantitative, and it sort of looks at the past and tries to extrapolate the future. Please remember that. Look at the past and extrapolate into the future, because I'll come back to that. Because this is a book, not sure if people know this book, Good to Great. Jim Collins is the author. He's become a millionaire writing this book and selling the book and giving talks about Good to Great. And what he's done with his team is he looked at the stock market performance of companies. So looking back, looking at how the stock evolved, the sort of time series, and then did lots of interviews, so the more qualitative research, and tried to distill from the quantitative and quantitative analysis what makes a company good and what makes it great. And one of the great companies in that book, you can actually look it up, is Circuit City. You know Circuit City? It's an electronics retailer in the US. It was given as an example of a great company. What happened with Circuit City? Given that you don't know the company, I'm assuming you don't know what happened with it. From good to great to gone. We went bankrupt in 2009. So this is a good example of how looking at the past, extrapolating the time series, great stock market performance, interviewing people how great this company is. You don't necessarily have the predictive power that it's going to be a great company going forward. And there's another, one of the McKinsey colleagues wrote a book, In Search of Excellence, which was the predecessor from Good to Great. And again, if you look at the companies being analyzed and were labeled excellent, quite a number of those companies don't exist anymore. They went bankrupt. So what I'm saying is any sort of extrapolation of the past into the future has its challenges, because you can't necessarily forecast based on insights from the past. So another book which, for example, the Harvard Business School will use, or other business schools will use, is what's called the Business Model Generation. Again, a quite popular book, and entrepreneurs often sort of use this and try to design a business model that will be quite successful. They don't base it on the past, they sort of imagine the future. They look at what are some of the key value propositions that they can offer to specific sort of consumers. They look at competitive positioning. They look at what are the key partners that are going to be needed, and they then project revenues and the cost structure. And then they go to investors and say, I have a great idea. Do you want to invest in my company? There's no track record, except maybe the person or the team that they may have done something in the past. But they come in with a great idea, and they're projecting the future in a way that is new and innovative, and therefore not based on necessarily past extrapolations. So we tend to use this, for example, also in the trust. When we approve business cases, we want people to look at what's the key value proposition, what would be the revenues, the cost, who are the key patient groups that we're targeting. So we want them to develop a business model or a business case. Now, sometimes the circumstances don't allow you to do that. So as a manager or as a leader, you sometimes just have to take decisions. This is a picture of the new intensive care unit, which is, those people that have been to the John Radcliffe recently, you'll recognize that this building is almost finished. Actually, the white building will have the same light brown color because we decided to reclad the old trauma building with the same external cladding as a new intensive care unit. But this new facility was decided in a couple of weeks, contract signed a few weeks later, and building started very quickly. No business case. We are in a COVID pandemic. It's no time for business case development. We need this. We know we're going to have more patients in intensive care. This was solved with a single strap line. This is pandemic preparedness for the future. And it's been built pretty fast as a consequence. But sometimes my point is you have to take decisions without too much reflections because you're in a different circumstance. These are a couple of examples of other companies. You probably recognize the logos. There's something in common that all these companies have. None of them used to have, certainly in the beginning, none of them used to have any building. Airbnb was the largest accommodation provider without any room, any building. Instagram was the most valuable photo camera without any cameras. Netflix had no cables, which was the biggest television network. Uber has no taxis. Amazon or Alibaba has no inventory. And Facebook had no content. So why I'm giving these examples is if you want to change global health, you don't necessarily have to look again at the past, because building hospitals may not be the future. Building large electronic patient records like we do here in Oxford or in some of the other European countries and in the US may not be the future. And these were teams that reimagined the future, were very creative. But creativity is only 2% of the effort. I mean, to get this, companies of these size is 98% is execution, is perspiration rather than inspiration. It's a lot of hard work to build these companies, even if you have no assets. You still need to build the infrastructure. Most of these are, of course, digital infrastructure. I gave these examples because healthcare will move a lot more towards the digital infrastructure. And if you take decisions in healthcare, I encourage you to reflect, do I still need to build these buildings, or can I actually reimagine the future of healthcare and use a digital platform, which also is expensive. I mean, the network of Amazon or of Facebook, I mean, it's a tremendous network, but it consists of servers and cables and that sort of thing. It doesn't consist of buildings and equipment. So I tried to give you a bit of a flavor of management sciences. And we talked about qualitative approaches, quantitative approaches, leadership, management, not necessarily looking at the past and extrapolating, but reimagining the future and applying these tools in a smart fashion, not just saying if it was useful in the past, we'll just extrapolate in the future, because disruption is happening. And I gave you some examples here of quite disruptive companies. That's why our high streets are empty, stores are empty. That's why a lot of disruption is happening in these sectors. So I'm going to switch to global health, which was the second exam question. And actually, somebody in the room told me that there was a very recent discussion in Oxford about what is global health. So you're going to help me. Again, I'm preparing you for the next question. How would you define global health? When you came here, what were you expecting to hear that we would cover under global health?
Perhaps global health looks at health across the world, across both low, middle, and high income countries, and the interplay between these countries, and how services are perhaps how services work in each country and how they transfer between the countries around the world. And I think COVID gives a good example of global health in that there are no borders anymore. And so the spread of health and the interplay between countries is not bounded by any limits.
Great. Anybody who wants to disagree? Yeah.
No, I don't disagree, but in my global health, all of humanity are one patient. That's the one.
Yep. So when you think global health should be something different, this is basically saying high income, low income countries, we're all in this together. We're affected by the same diseases, the same infections, the same diseases. So is that?
I mean, not necessarily. We're not like high income countries don't face the same problems that low middle income countries do all the time. They may do, but they don't always. It's more about how the high and low middle income countries can work together to impact health and how they can help each other with health outcomes.
So this is a discussion that's already going on for quite a while. And in 2009, there was a good Lancet article that was cited quite a number of times that was looking at, we need a definition of global health. And if you actually look at the London School of Hygiene and Tropical Medicine, that's a pretty old school, and that's probably why they call it hygiene and tropical medicine. We have here a master of international health in tropical medicine, and we also have a global health group. So it's all a bit confusing. So the Lancet said it is confusing, and they put it, this is the table coming out of the article from the Lancet, and they compared global health, international health, and public health, and tried to give definitions for each of these terms. And you were spot on. Global health is defined here, focuses on issues that directly or indirectly affect health, but that can transcend national boundaries. Yeah, that was, I think, your point, how countries can help each other. COVID is a good example of that. International health is defined more as issues other than one's own, and they use especially the term low and middle income countries. So when international health is used, it's sort of health in low and middle income countries. And then public health is looking at the population to do this. Yeah, it's all, it's a population where one patient, but then in a specific community or country. Now I'd like to give a bit my own definition of global health, which is that we can learn quite a lot from each other in the different systems. There are best practices in every country. To your point, the disease profiles are a bit different, but I'll come back to that. They're becoming increasingly similar. This is more about the global community that tries to apply insights from leadership and management to improve health of the populations that you as a leader serve. And that could be local, it could be national, it could be on a more global scale. The issues we're facing in the countries, can you, I mean, from your perspective, what are some of the issues that you think the health community, the health leaders are facing? You can just look at your own country, or what are some of the key challenges you believe your country faces in health? Don't focus on specific diseases, but more on what are some of the...
Health resourcing is a huge issue across Africa, in South Africa in particular. So forget about doctor-patient ratios, but nurses and allied health sciences, and in the flight of that capital, once it is developed in Africa and other parts of the world, is also a huge issue. So retaining the human resources to develop.
Yep. So it's about manpower, resources, also financial, not just people, but also money. Omar?
Access to new therapeutics. So usually you get a lot of small molecules that are widely dispersed, but things like, your latest gene therapy, like inhibitors, or even curative treatments, I think there's still a big problem in equitable access to biological therapeutics.
Yep. you're planning to come in.
I think there's also one of the issues is the demographic change in increasing aging populations and the implications that are attached to that. So increasing chronic diseases, for example, and the implications it has on healthcare costs and demand.
You want to read? You want to come?
Also, the knowledge of technology. So technology is making what the kind of interventions that the school of the healthcare system are approaching infinity, but the resources are limited. So deciding what to do
like how to influence the health seeking behavior of people from different backgrounds, which have influence also by their cultural background.
And lots of hands coming up now. Yeah.
So health security and health inequity. We have issues with high out-of-pocket spending and disparity in access to quality healthcare between the high-income class and the low income.
For me, it's about health being honored, especially in relation to other governments such as politics and economics.
Somebody, not recall who wanted to comment.
Javier mentioned this, but I think inequity within the country between the high income and low income, and also I come from Indonesia, and it's a big country with thousands of islands, and it's so hard to distribute resources to all the areas evenly.
Did you want to come in the back, or was that?
Yeah, I understand lots of how health is good is so the government in England, political issues, and it's not a thing that actually it's not a point. There are other things how people feel political and actually how
I mean, somehow get the feeling you're describing the National Health Service to me. So you talk about not having enough people, not having enough money, health inequality. You probably know that Oxford has some of the parts of Oxford are among the poorest areas in England. They're in the top decile of poverty. And they're about a mile apart from some of the richest areas in Oxford, but also in the country. So the life expectancy difference between those two areas, people living not even a mile apart, is about 10 years. I make this point because you mentioned resource constraints, money, people. You mentioned inequality, access to innovative treatments. NICE is a big gatekeeper in the NHS. The US, for example, is a lot better in that respect of adopting new technologies. So
there's a comment from the chat, from the online respondents, and someone said Buthania, sorry, I may not pronounce it correctly, said lack of leadership and managerial skills in managing healthcare services. And then we have another comment from Busila, who says, presently in Cameroon, it's the issue of insecurity and difficulty reaching remote populations due to the current Anglophone crisis. Also, the socioeconomic instability has led to a closure of many primary healthcare facilities, leading to a wide health gap and inaccessibility to many citizens.
Great. I'm going to move us on to what I believe are some of the global healthcare challenges. And somebody already mentioned the demographics. And there is an aging world population, growing middle class, but also a rise of a lot of the non-communicable diseases. Of course, sometimes we get surprised by an infectious pandemic, but I think the epidemic of chronic disease is certainly still running in the background. It's not going to go away. Resourcing, I sort of mentioned the NHS doesn't have enough nurses, especially. We recruit on a yearly basis about 250 nurses from outside of England. We don't have enough trained nurses in the country. We try to recruit them in areas that train a surplus of nurses, but still on a global scale, there's not enough trained healthcare workers. And then healthcare costs are rising very fast, and it's a real concern of many. So we need good leadership and management to solve those. The reason why I said a lot of the issues you mentioned from your own country actually are also in the NHS, is just to make a point that the challenges are global and they're pretty similar. And the next slide gives you the burden of disease by underlying cause. And this is a chart from our World in Data. You probably know the website. Quite handy, developed here in Oxford. And this is a chart from 1990, so more than 30 years ago. And this is the global burden of disease. And number one is infectious diseases. As you can see, quite a significant bar. Neonatal is the second burden. And this is, of course, over the life span of a person, and it's expressed as in values. Now, what would be the number one in 2017 is the most recent year that's available on the same website. What's the number one in 2017?
Oncology or cancer? In terms of
I must say, I thought you were right, but when I looked at it, I was a bit surprised because it is indeed cardiovascular. This is again global.
Or burden?
Sorry?
Is this just burden, like number of people diagnosed, or deaths?
No, it's the disability adjusted life years. So you see that neonatal is still pretty high up because these are young people. So of course then if you over the lifetime, it adds up. So this is the disability adjusted life years. You can take other, you can take mortality or any other parameter. My only point of these two slides is that, again, similar to the challenges, if you look at it from a disease perspective, we're coming closer to each other. It becomes really a global, more global issue. And even though in the past, probably before the pandemic, we would have said infectious diseases, especially still in low and middle income countries, but now you see how COVID has impacted us all. The other thing which is similar across countries, and it was mentioned before, examples of different countries, whether it was Indonesia or other countries, inequality actually is within the country, within a region such as Oxfordshire, and it is decreasing. The inequality. Here you have a sort of a plot of percentage of population with comorbidities, but you can also look at in terms of wealth. I mean, there's lots of parameters, and you'll see the same sort of disparity in terms of inequality. So these are a summary of all of the problems. Not enough people. We have changing demographics with an increase in some of the cardiovascular cancer, those diseases. Not enough money, concern about the rising costs. Of course, we want to fix the problem that was put in the chat on the webinar, lack of leadership and management. That's why you're all here, because we're going to solve these problems. So what's the solution? Limited funding is in every country. When you go to a US hospital and you talk to a chief executive, she will say, I don't have enough money. I'm going to charge the insurance companies more money because I need more money. Rising expectations and regulation across all the countries. Patients are expecting more. Increased costs, especially when you think about gene therapy, biologics, expensive drugs, and the demographics that leads to an increased disease burden. So what's the solution? My view is that now give a couple of examples of what I think are some of the tools that you can use as leaders, managers to help solve some of these problems. I'm a strong believer that we all should focus on patients / populations. That should be the driver. That's why people join the healthcare sector. So you need to really have a patient focus. This is a great chart of one of the gurus of quality improvement, Don Berwick. And he gave a presentation dressed in a patient gown and said, why I fear becoming a patient is to be made helpless before my time. It's to be made ignorant when I want to know, to be made to sit when I wish to stand, to be alone when I need to hold my wife's hand, to eat what I don't wish to eat, to be named what I do not want to be named. And he goes on. And actually, when you read it, and if you have been working in a hospital, you say that's exactly what we do. I mean, I've seen professionals talk to an aging person as their child, helping them to feed when actually they could probably feed themselves. And so we make patients helpless. We treat them in a way that actually we don't want, and we all realize it. And still, we all still do it as healthcare professionals. So I'll give a couple of tools that may help you, because he's a sort of founder of the whole quality improvement, having patient-focused efforts. What I suggest, if you have the opportunity to lead, even if it's only a team or an organization, part of an NGO, if you're part of the Ministry of Health, and if you have a leadership role, is don't study till eternity, but have a very action-oriented focus. And one tool that I'm encouraging my clinicians to use is the Plan, Do, Study, Act. Because a lot of people are saying, I want to wait for an approval. And they say, can the chief executive of Oxford University Hospital approve this? And I say, well, what do you want to do? Why can't you do it? Plan something, start doing it, study it. And if it works, then potentially one of your actions can be, listen, this was my idea, I've done it, it works, now I want to roll it out. But for rolling it out, I need more money, I need more people. But if you have then the evidence that this works, because you studied it, then you'll be able to get the money to increase the scale of your planning and doing. There's a lot of, this is an example coming from industry, this is the lean framework. There's a lot of what people call waste in the system in healthcare. Getting it right the first time is a big program in NHS England. It's trying to eliminate the defects, get it right the first time. This comes from the automotive industry, making sure that your car rolls off the production line without defects. Overproduction. People order too many tests without a real purpose. If you order a test, you should ask yourself, whatever the result is, what will I do as a consequence? And if your thing is, whatever the result is, actually I can't do anything based on the result. Whatever the result is, you shouldn't do the test. I mean, why would you put a patient potentially at harm when the outcome will not make a difference in terms of the course of action? Waiting, we talked about waitings in the patient rooms, doing some quantitative waiting line analysis, queuing. I mean, this is wasting a lot of time of professions, of patients, and not good. Underutilizing people's talents, it's called working at the top of your license. It's making sure that we don't ask doctors to enter codes to order a COVID test, which we do in Belgium, for example. We have highly trained people that have to go on the PC to order a PCR test for a patient, which is not the best way to do it. You should do it. The patient himself could do it. We should think about what can the patient do, him or herself, because there's lots of things that patients can do that would free up a lot of time of administrators, nurses, and doctors. Transportation. Why do we ask patients to come to the hospital if you can do a remote consultation? This wasn't possible before COVID. Now suddenly everybody wants to have a remote consultation because it's easy, unless you of course need to have a physical diagnostic or an examination. So I can go on. I mean, these are some tools that people are using. And actually, to give you an example, this is a picture within the hospital up the hill. What do you notice here? Sorry, this. Yeah. So the team was asked to do this lean approach in this department. And what often is the outcome after a lean exercise is a storage unit that looks quite different. With and actually, when you go to a factory floor, you often see they put these stripes on the floor, and that's where the bins need to be. That's where you need to put the stuff, and it needs to go back there, not to another place, so people can always find it. Also, the supplies are neatly organized. The stock is better managed. You have to go. I mean, I invite you to go to some of the units in the hospital up the hill. It's complete chaos. And you ask, do you still use this? No, we don't use it. I mean, there's lots of opportunities that you have by applying this. And there is one wisdom that I would like to share with you of a much smarter person than I am. But he said, insanity is doing the same thing over and over again and expecting a different result. So if you want to achieve change and to improve quality, to improve productivity, we're going to have to change the way we work, which is quite uncomfortable. People like to do the things as they always done, patients and health professionals. But if you would like to have different results, better outcomes, higher productivity, you're going to have to change the things, what you do. Otherwise, you get the same productivity and the same outcomes. So I'm going to go back to one of the slides I used at the beginning. And focus this time on decision making. So here, this book was suggesting linear programming, time series analysis to make sure that you made the right decisions. Now, as a chief executive of the hospital of the hill, or as a leader of an NGO in one of your countries, or being part of the Ministry of Health, or whatever organization you're going to have a leadership role in, what decisions do you expect you will have to take? Give me a couple of examples of decisions that you probably have to take, even as a team leader of a team of 10 people, providing some service to increase the health of a population. What sort of decisions?
Firstly, like whom to hire, how many people to hire for the project, because in project HR is always least funded. Then I mean, where does the fund goes to? I mean, for what services? Dividing the services. Are these like the long-term services or the short-term outcomes you are looking at? So yeah, funding, like where the funding, allocation of the funding. That's the other thing.
Would you use linear programming to recruit the right people?
No, not really, but as decision making, I was looking at that.
So what sort of tools would you use to recruit the right people?
It will be more like, I mean, we have to look at what disease we are looking at, what the program is, and which community we are working in. Who do we need? Do we need managers? Do we need project leaders? Do we need like healthcare workers? Or do we need people who can do the MIS system? So yes.
Yeah. Good. Okay.
For me, it would be prioritizing resources, prioritizing your strategic plans. What do you have? How much do you have? And where do you want to go?
A lot of the time, also take into account what stakeholders are there. So I mean, for example, I work in industry, a lot of the time we get told how much to produce, how much to stock, how much inventory you have to hold. And the fact is everyone wants to produce a lot just to give medicine away for free. But at the end of the day, you have to keep your shareholders happy. You have to ensure that, you know, you're not stocking up too much, having unnecessary costs. I think a lot of decision making, no linear programming helps how to keep all stakeholders a part of your organization, externally and internally happy.
Yeah, so recruiting the right people, setting priorities, managing stakeholders. What else would you do?
I have to decide the strategic vision. Where is the organization going in the short, medium, and long term? If that vision is aligned to the aspiration of the community.
I was going to say, maybe what the patient tracking can because a lot of the time you get to what patients want, like a lot of all the different hospitals. Somebody comes to the hospital and says, pneumonia is an organized best friend. And we don't actually let people drive pneumonia because they can't even treat them. So maybe that's what the community wants.
So I reflected back on the decisions I've taken in the past, it is now almost 20 years. I've been Chief Executive of Health Systems. And they are easily put in 4 buckets. So I agree, you need a vision. You need to make sure that you understand the patient needs and you respond to the patient needs. But in the end, when when I'm asked to take a decision within my team, they tend to be one of 4 things. And it boils back to, I want to recruit more people. I want to recruit different people. I want to organize a training program for people. I want to do retention strategies for people. It's about the people you need. You need the right people. Yeah. So training, developing, retaining people. That's where we have a lot of sort of decisions that come to us. To recruit, for example, people, nurses in Kerala in India, because we don't have enough trained nurses in England. That's a decision that comes to the executive level. I didn't hear systems, but there's a lot of decisions that we have to take on equipping those people with the right tools, and investment in digital applications, in electronic patient records, in linking it up between organizations. Those are, again, important decisions that we tend to take. Building a new intensive care unit, changing the layout of the department because the care is now delivered in a new fashion, and the way it was designed in the past doesn't support that process anymore. So we need to refurbish or build something new. And also the suppliers. We want to have biologics, we want to have new medical devices. These are the decisions that we take. And it's not always easy to get the right information on making sure that you take the right decision. But I've learned that it's always better to take a bad decision than to take no decision. And I've seen too many organizations that are postponing the decision because they think they're not going to take the right decision. And actually the organization and the population they serve is actually worse off because of a lack of decision. So if you're a leader, you will always be a bit uncertain, am I now taking the right decision or not? But then remember, it's better to take a bad decision than no decision, because you'll never have perfect information.
How do you force yourself to make decisions rather than keep procrastinating? Because I keep reminding myself of this quote, just in my personal life, and it's very easy to convince yourself that with, in the next week or 2 weeks, you'll get a flurry of new information which will help you make a much better decision.
Probably experience that matters, because if you ask sort of colleagues, why do you take a decision or why don't you take a decision? And in most cases, people regret taking the decision too late. They almost never regret not taking the decision. So it is more experience, and of course, when you build an intensive care unit during a pandemic, the margin of error is a bit higher, the tolerance, yeah, to make an error, but it's sort of a bit of the context. But you're absolutely right. You should constantly ask yourself the question and err on the side of let's take a decision, even if it's not perfect information yet. We should take a decision. The other thing which I heard was setting priorities, managing stakeholders, and I've added here building a team. This is what most leaders do, is they set priorities, they're linked to the vision. So when you look at what Amazon did or what Airbnb did, they had a vision, but they also were very clear on what are the short-term priorities and how do you build the company. So being clear on what the priorities are, building a team that can execute on those priorities. And that was something that you mentioned around having the right skills, the right profiles, depending on what you're trying to achieve, is really important. Nobody can work by themselves. Every great company was built by teams of people, not by a single individual. There may be a visionary leader, but he or she needs a team to execute. And I would really also look at managing stakeholders. And that's both internal and external. I've seen too many leaders fail because they failed to map the stakeholders. And they were a bit naive that people would follow them because it was so obvious that they were right by setting these priorities, building this scheme, but forgot to actually engage with stakeholders, which could be internal or external, where people have different perspectives and would potentially disagree with the priorities you're setting, disagree with the team you're building. And if you get that and you have some powerful stakeholders, they will make sure you fail. So managing stakeholders is also extremely important. So hopefully you got a bit of a sense that there's some exciting tools and methods out there when you go and study for an MBA or when you do a PhD in economics, whether it's linear programming or financial valuations on stock markets. I mean, very mathematical approaches, but in the end, leadership and management also comes down a lot to common sense and experience. And so I would encourage you all to start managing leading, learn on the job, and use some of these tools, but not stick to them as it's the only thing that you should use, because sometimes people use these tools in the wrong settings and it's garbage in, garbage out. So common sense always is helpful. And we all have common sense. We sometimes forget to use it. So thank you for listening. I'm more than happy to take more questions today. If people still want to ask me questions rather than me cold calling you. But at least thanks for listening.
Okay, so I think this is time for question and answer. Sunday, will you happily moderate that? Or maybe whoever, maybe not necessarily, whoever has a question can just raise their hand. I think Bruno can happily ask them. We have some questions from the audience, but from the online audience, but maybe we'll start with those of us present here.
I was just thinking about how many healthcare systems, how many doctors, how many board. Because working on the board, we talk about how to make patients helpless. You know, we do feed people that don't eat feeding, keep them in bed all day, they don't eat in bed. And like, there doesn't seem to be much, well, I don't really know, but there's never enough HCAs on boards, and like, who makes the decision about, because I think that's what we need, more people that are good with patients, even if you have to encourage the patient to do themselves. Like, yeah, who makes the decision about numbers?
So it depends on which organization, of course. I can describe you a bit what we do here in Oxford. We have offered some of the, we call it the ward managers or the people that manage operating theaters. We try to equip them with some of these tools to make them challenge the way people do things. But sometimes you have individuals that have led the service for 20 years and have led it in a certain way, and it's very hard to change the way they operate. So I'm a strong believer in training people, and when lots of these services are clinical led, they tend to be nurses or doctors or physiotherapists. They usually have somebody with more of a managerial background to work alongside them. But the clinicians don't have a lot of managerial or leadership training. That's why we invest in some of these programs and some of these, learn them how to use some of these tools. And the reorganization of the storage room was coming out of the quality improvement program, applying some of the leading principles. So you can do this at a pretty small scale in a certain department or a ward of a hospital. And when you challenge them, say, can't you reduce length of stay? Can't you move these patients to day case? Can't you? People, I mean, certainly here in Oxford, they take up that challenge, and we've had significant moves in terms of day case treatments, reduction of length of stay, making sure that we mobilize patients a lot earlier. After significant surgery, they come out of intensive care almost on the same day. So they go early in the surgical suite. They then go to intensive care, and by the evening they're back in the ward. And the next day we start mobilizing them, including encouraging them to feed and etc. It's all possible, but sort of early rehab. So all of these things. I mean, there's great ideas around the world, whether it's here in Oxford or anywhere else. It's how you adopt that across settings, even within an organization like OUH. We try to then exchange best practices and make sure that people can actually see that something is possible by visiting another unit. We do that through peer review, so we encourage them to go and look somewhere else. And so there's several tools to be able to empower people to make the right decisions. And when I joined here, the organization was used to almost having all decisions being taken by the board, sort of the senior leadership. We've been trying to move that down and say, you can take decisions, you can do this, plan it, do it, study it. If it works, and you then need some investments to redesign the unit or to whatever, will follow. But you should lead it. In the back. Sorry.
Yeah, so thank you for the talk. It was really interesting. I'm sorry I wasn't here for more of it. But basically as part of your job, you're managing a vast enterprise essentially with a lot of people, and much of that would be day-to-day immediate management of it. But I think I would be right in assuming that some of it would also look at long-term planning and sort of trying to implement policies or resilience measures to ensure that whatever challenges you face down the line are mitigated as much as possible now. How much of your time would you say is spent, let's say, future-proofing, and what would you say are the biggest problems you have to deal with or have to plan for using the immediate future? Say, like, whether it's workforce retention as a result of Brexit or something like antimicrobial resistance, the rise of that within clinical settings. So could you talk a bit about that?
Yeah. So I mean, I'll give the examples during the pandemic, because we had to deal with all of these issues, but future-proofing and retention and staff well-being. So all of the decisions that we've taken, and sometimes it was a daily decision that we had to take in fast response to the first wave of the pandemic, whether it was ordering PPE or whether it was redesigning the flow in the hospital, redeploying people. I mean, if I go back to these 4 decisions, we had to make an amazing amount of decisions around redeployment of staff. We had to implement digital technology to do video consultations. We had to connect the GP systems with our system. Lots of decisions on systems. Space, it was just, the whole physical distancing, redesigning the flow, making units COVID safe, suppliers around PPE, testing. all of that. I mean, there were daily decisions, and it was very much top down at that point in time. We didn't ask a ward manager to take those decisions. This was the executive team being on a Teams call at 7:30 a.m. every morning, say, what decisions do we need to take? Yeah? And it was not using business cases. We would say, go ahead, yeah, order that, place that order, make that contractor do it. Yes, we're going to redeploy these people. So that was I would say, the emergency response. But even then, we said, let's use a local supplier that was giving us basically masks that we could use in intensive care units, but were reusable. It was a local supplier. So we said, let's use that supplier, because we can then fit test people on their mask. They'll have their personal device, which we can use throughout the pandemic, because we realized we didn't expect it would be 2 years or more, but we certainly knew it was going to be more than a year. So we took decisions also with a longer term view. The intensive care building, for example, was with a very long term view, and fortunately we were in a situation where we had developed a master plan for the John Radcliffe site, the Churchill site, and the Knox site, where we already had developed this with architects and urban planners, where we would do certain developments. So when we had to build the intensive care unit, we knew exactly where we wanted to position that. We could move very fast. But that master plan, I mean, actually is a vision for the next 40 years. And we want to build a life sciences campus here in Oxford, together with the university, both universities, also Oxford Health. So how should Headington look like 40 years from now? So a very long time, long-term view in terms of the spaces, but also in the staffing, I mean, in terms of training, health professions, we're talking about 5 to 10 years as a time horizon. System investments, we need to develop the architecture of the digital infrastructure now. And again, the vision is that all of this will move to the cloud. So no servers necessarily based here in Oxford. The servers will be somewhere in a farm. So to give you an example, most of the decisions we take have a long-term planning horizon when you talk about these sort of decisions. But that's because we're operating at the board level. When you would operate at the ward level, ward manager, the decisions tend to be more shorter term. Is how can I have sufficient staff for the next year? How can I make sure that I have the right sort of shifts? Yeah, so they tend to be shorter time horizons. And there's actually a nice leadership sort of profile that the more sort of senior you become in your leadership skills, the more longer term you should be able to plan. So it's that, and people test it. Yeah? How comfortable are you planning with a long time horizon and taking decisions with that long time horizon? So most chief executives of larger organizations will have an ability to plan in a time horizon of 10 to 40 years.
Thank you. I listened to you say on another platform that quality care is actually patient care. Now, if one like the patient care comes with cost necessarily, how do I marry that with Uma's concern about making novel therapies which are very expensive accessible? So I just want to know how you marry the efficiency and quality of care with the rising cost of care and then making novel therapies accessible to the average patient.
So clearly the very expensive biologics are adding costs. So I think the point you were making is that higher quality also leads to lower cost. Clearly that doesn't apply to high cost biologics. Right? They may improve the outcome, but it comes at a significant cost. That's because you're looking only at one piece of the, if you take this at the whole patient journey, or if you look at it from a population point of view, You can allocate budget, because that's what we're talking about. Most leaders allocate budget, that's what they do, allocate budgets to, you can recruit so many staff of these profiles, you can have so much space, you can invest this in the systems, you can buy expensive, it's budget allocation, and it's a scarce resource allocation. So if you do that well with the perspective of maximizing patient outcomes, which is what we're all here for, it's increasing health for a population that you're serving. How can you allocate the resources in such a way that you can maximize the amount of the qualities or the DALIs for your population with the limited resources you have? And then often it may be the case that you could use some expensive biologic, but that could be the right answer, but not always. And the same applies with very expensive surgeries. Clearly, if you do a late stage cancer surgery that takes 12 hours and only adds 4 months of a person's life expectancy, yeah, you could probably use that in a better way, but it's often hard to do that reallocation of resources. But when you bring in new technologies, you can make that decision. And of course, I was saying NICE is a gatekeeper because they want to also manage the budget. So they put a value to a quality. And if your high expensive biologic doesn't meet that threshold, it's not going to be approved. So that's a way to manage.
You led a public organization and a private, and within health as well. What do you find primary differences are between leading a public organization and a private one?
I'll ask it from a personal point of view. I'm an absolute supporter of universal health access and a public payer. And it could be a single payer, but certainly either a tax-funded system or a social security-funded system, because that is required to increase the access to health. My other very strong belief is that private organizations are much better to execute. And I've encountered very few public providers that are very efficient. But there's so many private providers that are super efficient. But this is it's going to be published right this webinar. So people will look and go back to what I'm saying here, but that is my personal belief. And we should allow public institutions to have the same degrees of freedom in terms of designing their HR policies, their financial policies, how they manage suppliers, the things that we talk about here, with the same degree of flexibility as private organizations do. Because once you put central controls and planning into place, there's enough examples that say that that is not always the best way to deal with it. So a strong believer of public payer systems which allow universal access and coverage, but a firm believer in entrepreneurship and private enterprise to execute. And if you're concerned about the profit motive, then do it with a social profit. But still, there's not, Belgium, for example, doesn't allow for-profit providers, only non-profit or social profit providers. So there's no shareholders that take away the money or profits that leave the system. I have one question in the back, and then I'll come to you.
I can just building on that and from your answer. So I guess I'm trying to understand that if you want to allow individual providers within a universal or single payer system to have the freedom and autonomy to formulate their own HR policies, formulate their own policies to implement healthcare, how can you guarantee that you would have sort of the optimal outcome across the board, right? Because isn't that sort of the theory behind a single payer system, that you maximize the outcomes for as many people as possible? That's why it's universal. So how would you try to guarantee the best possible outcome if you allow kind of a very devolved level of power and policy making?
But the commissioning, if to use the language that's often used here in the National Health Service, the commissioning could be public. You could commission the service if you want, and you would commission more preventive services. And we were, for example, now commissioned to do early lung cancer screening. So we target high smokers in certain areas and offer them a CT scan to detect lung cancer. Actually, we detect a lot of lung cancers in individuals without any symptoms. So that allows us to operate on these people in an early stage rather than in the late stage and offer that curative treatment. So as a commissioner, you could commission that sort of service. The provision of the CT scans, actually a lot of the provision in this country is already happening by private providers. We work with private providers who do the diagnostics and other sort of services. I think your concern is you should keep the commissioning public so that you commission the right services. But executing the services can be done in a private context. We have a question from the...
Yeah, we have a question from the online audience. So the question says, what is your personal take, premised on your training, career, experience, and insight on apex managers of healthcare facilities being well vested with formal background, training / education in both the depth and breadth of health and healthcare and management science?
Oh, that's a question. And I missed the middle part of it. So
I think
can you try to rephrase it in a short question, and I'll try to answer.
I think he just wants to know what your thoughts are about. Do you think it's valuable for healthcare managers at top level to have formal training in healthcare and health management science?
Yeah. So it depends a bit on again what position the person is, because I get that question a lot. And should I do an MBA or not? I assume you're a clinician.
Yeah.
And so there's lots of clinicians that want to take on a leadership role in health, global health, and then are a bit struggling with, I've already done so many years of clinical training. Should I now do so many formal years of management, leadership training? It depends on what your real ambition is. If you want to become a chief executive of a large healthcare system, a large organization, the answer is probably yes. I mean, and a lot of the things you can learn on the job, or do some workshops, or do sort of 3-day training sessions. But the sort of structured learning that you have in an MBA program or a master's program, and it's especially around finance, is where I find people are struggling, because people can get quickly sort of how you do recruitment and how you manage people. I mean, it sort of becomes natural because the people that go into clinical professions are very people-oriented. So I mean, that comes pretty natural. But what doesn't come very natural is finance, and having an understanding of what is cash flow, what is cash, and what is an accrual, and how you put it on the balance sheet, and how that impacts the P&L. I mean, I've had endless discussions with clinicians trying to explain the balance sheet and the P&L. I thought I had done it clearly, and clearly in the next discussion they were still confusing. So there's probably something around formal training in certain areas that is pretty helpful if you want to take a full-time leadership position. If the person is interested in doing this, like a number of our clinicians, they still practice, but they still need a significant service, and they need some management training, then you don't necessarily need to do an MBA, although some of them do. We have an affiliation with Brooks that also offers an MBA, and they sort of still opt to do that because it's a part-time program that they can opt into. I'm conscious of time. People must be getting hungry, so unless there's other questions. Yeah, we have one last question.
I want to know your take on how to do fiscal triage, because I think it's very easy for us to sit here in the room and then say what treatment is cost effective and what's not. For example, if this patient has 90% mortality for this particular disease that he's having, then we probably shouldn't give him like this the most expensive state-of-the-art treatment because it's probably going to fail anyway. But if taking the patient as a human, if you're in the family's position, then you would probably want to know about the treatment. And it's very hard to make a decision, say, would I want to spend £1,000 on this medication that may have a 10% chance to save my parent's life? I find it hard to, should I tell them about this medication or should I not? If I tell them, they're probably going to take it, and then that may impact their financial life quite a bit. But if I don't, then I also feel that it's not my, I'm not in a position to point God and not tell them. So where do you think we should stand, and how should we act in cases like this?
I will then go to somebody that leads our ethics department. Because these are difficult questions, and depending on the area of medicine, there's some very significant ethical issues that also link to societal choices. So I feel we need to support clinicians in that decision making. So, for example, during the COVID pandemic, we were concerned of not having enough intensive care capacity, and potentially have to select patients who could go into intensive care and who couldn't. And how would you prioritize that? We actually did ask people with a different expertise, not necessarily a management or expertise, but could deal with some of these ethical issues in a way to then advise the management and the clinicians on how to deal with these tough issues. I think it is not good to just put clinicians in that difficult position without some advice and guidance. And again, the advice and guidance you'll get probably depends on the circumstance in terms of the country you're operating in, potentially the organization you're operating in, and even in England or in OUH, it may depend on the external circumstances. If you're in a pandemic, it's going to be different than if you're not in a pandemic. So I find that a difficult question, but it comes back to the question in the back of the room, and I don't know the person's name, but about the commissioning. I think actually that's a strong point in England, is that you have strong commissioning, strong views on what is being made available free to all residents in England. It sometimes means that some treatments are not given to patients out of the NHS budget. Then you're in a difficult situation of, if you know that treatment exists, but it's not offered in the NHS, do you then advise patients to go private or to go to another country to seek that treatment? But if you have at least a commissioning arm that is pretty clear on what is offered free to all residents of that country, you're putting your clinical teams in an easier position than if you don't have that sort of framework. Very good. Hopefully you can enjoy the rest of the evening. Thanks for coming.
On behalf of the Executive Committee of the Oxford Global Health and Care System Society and the members of the society, I want to really express our profound gratitude to Bruno. I know he's a very, very busy person, so having to get him to take out an hour and a half of his time to speak to us today has been very valuable. We also appreciate the members who are here. Of course, this is a cross-section of both members and non-members of the society, and the audience who have been with us since we started at 6:30. We're really grateful to everyone, and we ask you to continue looking forward to our event, and hopefully, sure, after this event, for those who may want to have chats with Bruno for a bit just before he leaves, should be able to do that. But otherwise, this will be the end of this event. We are already planning a speaker event for next term, and that would come up between end of January and early Feb. And I'll be looking at the link between Big Pharma and global health. So we're getting someone to talk to us about that, and we'll publicize that once we finalize it. So, like we always say, we ask members of the society to please reach out to us with topics they think are relevant for us to discuss, and also interesting speakers like the like of Bruno that have the experience and the insights to help us become better leaders in global health and practitioners in general. Thank you very much. So.
Thank you so much for your response. Very good.